Immunotherapeutic approaches have really come to fruition in myeloma in the past couple of years with the introduction of two monoclonal antibodies, both of which have been approved by FDA in the past year for treatment of multiple myeloma. Now, elotuzumab is a monoclonal antibody that is directed against SLAMF7, a protein on myeloma cells. Currently, elotuzumab is approved for treatment of multiple myeloma that have had at least 1 to 3 prior therapies and have relapsed after the last treatment. It is approved in combination with lenalidomide and dexamethasone, and this is based on the results of a phase 3 trial which looked at the combination of elotuzumab, lenalidomide and dexamethasone, comparing it to lenalidomide and dexamethasone in patients with relapsed myeloma. And that trial showed that there is a significant improvement in progression-free survival by using elotuzumab, leading to its approval in that particular group of patients. Daratumumab is a second monoclonal antibody that has gone through clinical trials and has recently been approved. This, in contrast to elotuzumab, this targets a different protein called CD38 on the multiple myeloma cells. Now, daratumumab has been approved on the basis of a single arm trial, unlike elotuzumab, which was approved on the basis of a randomized phase 3 trial. So, daratumumab is currently approved for treatment of multiple myeloma that has progressed after 3 prior lines of therapy, or multiple myeloma that is refractory to both a proteasome inhibitor and an immunomodulatory drug. Daratumumab is approved as a single agent for use in multiple myeloma, in contrast to elotuzumab, which is approved in combination with lenalidomide and dexamethasone. Patients with multiple myeloma go through a variety of different treatments over the disease course. Now, one of the things that has dramatically changed the outcome of patients with myeloma in the past decade have been the introduction of proteasome inhibitors, the first one of which was bortezomib, and immunomodulatory drug, the first one of which was thalidomide and then lenalidomide and most recently pomalidomide. Now, these are probably the two most effective classes of drugs that we have in multiple myeloma today. And one of the most common initial treatment of multiple myeloma is to use a combination of a proteasome inhibitor and an immunomodulatory drug. So once patients become refractory to both these classes of drugs, or a drug each from each of those classes, the outcome of patients from that time point tends to be relatively poor. In fact, there was a study that was done looking at a large group of patients from multiple countries, where we looked at what the survival of patients are after they become refractory to one drug from each of those classes. And it seemed like the progression-free survival was roughly about 5 months, and overall survival was about 9 months from the time patients became refractory to both those classes of drugs. Now, clearly this data is about 7-8 years old, and the outcomes of patients have since improved because of the introduction of new therapies. So patients who are double refractory to both a proteasome inhibitor and an immunomodulatory drug tend to have poor outcome. So these patients really need new therapies that belong to a different class of drugs in order for us to be able to bring the myeloma under control again.
A cycle of daratumumab therapy, monotherapy, is 4 weeks long. And for the first 2 cycles, the daratumumab is administered once weekly. For cycles 3 through 6, the antibody is administered once every 2 weeks on days 1 and 15. For cycle number 7, it's administered on day 1 at once every 4 weeks. The dose of daratumumab is 16 milligrams per kilogram. Elotuzumab is administered in combination with lenalidomide and dexamethasone. Again, the cycle is 4 weeks long. Lenalidomide is administered on days 1 through 21 of the cycle. The dexamethasone is given on a once-weekly basis. Elotuzumab is administered at 10 milligrams per kilogram IV once weekly for the first 2 cycles, and then it's administered once every 2 weeks for cycles 3 and beyond. And again, just like with daratumumab, treatment is until disease progression. There is, a real risk of infusion-related reactions, particularly with daratumumab. In the initial studies, the rates of infusion-related reactions was on the order of 40 to 50%. Because of this, pre-medications are certainly required. With regards to daratumumab, patients are treated with diphenhydramine or Benadryl. They receive a dose of acetaminophen or Tylenol, as well as a dose of dexamethasone or other corticosteroid equivalent prior to each dose of therapy. As it turns out, it appears as though activation of basophils in the nasopharyngeal tract and upper respiratory tract may be responsible for some of the unique infusion reactions that you see with daratumumab, and there's increasing anecdotal evidence to suggest that a dose of montelukast or Singulair administered the day before the first infusion and the day of the first infusion can mitigate some of the infusion-related reactions that we do see with daratumumab, making it easier to administer on a single day. The rates of infusion-related reactions with elotuzumab are far less than that of daratumumab, approximately 10%. In both cases, the infusion-related reactions typically are grade 1 or 2 in severity. Grade 3 is very rare. Grade 4 and 5 typically are never seen. And the other important thing to recognize is that the infusion-related reactions are really a first dose phenomenon. You very rarely will see an infusion reaction with the second dose and beyond. As far as pre-medications for elotuzumab, typically patients are pre-treated with a dose of corticosteroid. So a dose of dexamethasone of 28 milligrams is given 3 to 24 hours prior to administration of elotuzumab. An additional 8 milligram dose of IV dexamethasone was administered within 30 to 60 minutes of the elotuzumab. They also received acetaminophen, Tylenol. They got an H1 blocker such as diphenhydramine or Benadryl, as well as an H2 blocker like ranitidine, for example.